Well, thank you, Dr. Rivers. That was an impressive tour de force, and there aren't a lot of people that I meet in my day-to-day life who've actually changed the world in the way that medicine's practiced. So kudos to you and your colleagues. I have a follow-up question about your presentation, and it drafts a little bit on Helen Haskell's comment in the opening session, and also on a comment from one of the public attendees, which is how do we think about early goal-directed therapy before patients get to the hospital? Is there interventions that we could put in place in the home with EMS, in nursing homes, that would allow for an impact? And where do you think that the field is going with respect to those kinds of opportunities?
Yes. One is what we call education. I think giving patients the education in terms of what sepsis is early, just like heart attacks and strokes, we made that transition. If you have chest pain or if you can't move your right arm, then come to an emergency department. I think the basic tenets of what we call the surge response, temperature, heart rate, blood pressure, can easily be transferred to lay language and subsequently allow patients to realize that they're potentially septic and bring them to the emergency department. I think that early diagnostics is key. You can order a lactate machine online to check your lactate when you're working out. So it's no stretch to say that the potential of even having a lactate measured in a nursing home patient or perhaps even at home is not too far out. It's just a matter of how far we want to take this. I think the diagnostics of measuring your blood sugars are there, and there probably will be a time where we can measure a biomarker platform that'll be readily read by a machine that'll help people interpret where you are in the whole sepsis cascade. So I think this whole session about the clinical use of biomarkers as well as diagnostics has great promise, especially in that patient population.
Thank you. I have one more question for you, and then I'm going to go after Dr. Shankar-Hari, who's been, I think, out of my line of sight for a minute, but I've got you. So my question is, when I was in medical school and was doing neurology, the attendings said that when you see a seizure, you shouldn't just do something, you should stand there and observe and see what's going on. In sepsis, the recommendation seems to be the opposite. Shoot, aim, shoot, point, and aim. And because of the benefits of early intervention. And so colleagues have also said that one of the challenges they have is that they are obliged to act aggressively and then retrospectively say, gee, I wonder if the patient had sepsis or not. So I'm curious your thoughts about that. There's a public attendee who also asked this a related question where the person says that there's data that SIRS criteria is associated with mortality. There's evidence that SOFA and QSOFA data criteria are associated with mortality. So, how do you think about the risk of mortality, and shouldn't, how do we risk stratify, and shouldn't we be more permissive in thinking about what are all a similar or underlying process?
Yeah, great questions. Number one, I'm an emergency physician and a critical care physician, so I wear different hats. And so when I'm in the emergency department, my main job, sometimes I don't know what you have, but what I want to do is make sure you don't die from it. So your early detection of high-risk patients become more important than the disease diagnosis. So if I have a patient that has SIRS and a lactate of 6, that patient's risk stratified to high mortality, and I may not see what the consequence of not giving antibiotics or what have you, but that patient has a high likelihood of death. And I think that what we have to do is understand that when we use diagnostics, it's based on a location of where that patient presents in a continuum of disease. And many times we didn't realize it, but 20% of all patients that were presenting with septic shock arrested and died on the general floors before they ever got to an ICU. We did not know that when we saw sepsis as an ICU disease, but when you look at the natural history of sepsis, that's actually what happens to these patients. And so I think it's important to say that if I chose to give you a dose of antibiotics and you have a risk stratified mortality of 40%, I'll live with an inappropriate antibiotic dose. And it's funny, you talked about neurology. When you take care of a stroke patient and a patient comes in and get ruled out for a stroke, only 1 out of 15 patients ever get TPA. The other patients are ruled out. Again, they may have other issues, but people don't talk about that. These people never get treated. But you spend 30 minutes and you go through a stroke scale and you appropriately examine that patient, but you never say, well, this patient didn't have a stroke, so it was a waste of time. But the key is we have to accept, and the stroke patients don't have mortalities that high. But the paradigm of chest pain, if you come in with an MI and you sit on that for 30 minutes, you can't get away with that. Risk, the mortality of an MI is less than 10%. So the key point is the corollaries and also the growth. We're talking about 1997 from the time we started checking lactate for sepsis in the whole United States. So that's a recent change in our practice, and I think we have to grow with that.
Thank you. Very thoughtful. Thank you. All right, Dr. Shankar-Hari, I have a question for you. I was impressed with your thoughtful presentation of how we moved from SEP 2 to SEP 3. And my question is, where are we going? Where are we going to land with SEP 4? What are the changes or innovations that you think may be incorporated as we begin to think further about sepsis diagnosis and how we define it?
Yeah, I think thank you. That's a challenging question. So my first excuse would be that I said it's sepsis 3.0. So what we've got there is a working kind of current understanding or current paradigm. So that needs to be tweaked or improved. In terms of where we are going, it's any disease definition or criteria has got 3 broad elements. There is validity, feasibility, and reliability of the diagnosis. Whenever we go down the more refinement based on any of the newer technologies, what you lose is feasibility outside of the kind of place where that sort of technology is available, and you gain reliability and closer to the biology of the disease that you're studying. So I think coming purely from a immunology perspective, I would say a lot of the early host dysregulated responses are conserved, not just for infection, but for any injury. If you look back in time, the Glue Grant paper essentially highlighted that early trauma insults, burns insults, endotoxemia insults, and sepsis insults are very similar in terms of immunobiology. So I think there may be a need to rethink the whole critical illness syndrome paradigm, where we could go from a sepsis ARDS buckets to critical illness with or without infection as a crude example. So it may be that we'll refine the overall critical illness. Within sepsis, we may go towards the points that Dr. Rudd and Dr. Rivers highlighted, which is you could have a different risk strata based on inflammation as an example, hyperinflammatory phenotype as an example. Dr. Seymour, who is going to speak next or at some point during the day, has used routinely available clinical data to stratify patients into 4 or 5 phenotypes. So that's the other option to go down to. What we haven't done, which we should do, is to go towards what I would call as a treatable trait, which is, the example that Dr. Rivers highlighted, which is if you have a chest pain and an ECG change, you wouldn't get away without kind of treating for an MI. And similar treatable traits are potentially there. We haven't been sophisticated enough to find those. So that'll be that I've kind of hedged my bets everywhere. Yeah.
That was a wise and astute approach. Thank you very much. I'm grateful to you. And in fact, I'm grateful to everybody on the panel and to the very thoughtful questions that are also coming from the public attendees. I think we have 1 minute to go, so I will give everybody back 1 minute. But thank you again so much for taking your time and trouble and spending time with us and preparing and delivering what are very, very thoughtful presentations that will inform the rest of the workshop.
Thank you so much.
Thank you. Mm-hmm.